Okay, let's dive right into this explainer. Today, we're going to completely demystify the somewhat abstract concepts of research and quality improvement. If you're prepping to ace the VABC exam, or honestly, if you just want to elevate your everyday clinical practice, you are absolutely in the right place. We're going to take what often feels like dry textbook theory and show you exactly how it translates to protecting your patients and saving lives right there at the bedside.
To keep things simple, we're breaking this down into two straightforward parts. First up, research and vascular access, and then we'll tackle quality improvement in practice.
But before we get bogged down in the academic weeds, let's anchor this with a real-world problem you've probably faced on your shift. Imagine your unit is suddenly seeing a huge spike in PICC line dislodgements. You'd probably stop and ask, hey, does this new securement method actually reduce catheter dislodgement? Well, that right there is exactly why we need research. We have to identify problems, test out solutions, and ultimately guide our best practices using data rather than just guessing.
So, let's kick things off with Section 1, Research in Vascular Access.
So, here's the deal. Understanding research is honestly what separates a mere technician from a true vascular access clinician. Evidence-based practice, or EBP for short, is kind of like a three-legged stool. You can't just rely on what a textbook says. You have to combine the best available peer-reviewed evidence with your own clinical expertise, your technical skills and pattern recognition, and then you always have to factor in patient values, like their personal preferences or cultural beliefs. If you're missing even one of those three legs, the whole stool just tips over.
Now, when we're gathering that evidence, we basically have two main tools at our disposal. On one hand, quantitative research gives us the hard, cold numbers. It's totally outcome-focused. We're talking about tracking complication rates, C-lab Psi incidence, or comparing device dwell times. On the other hand, qualitative research explores the very real human experience. It answers the "what does this actually feel like?" question by looking at things like patient fear, staff feedback, and everyday workflow observations. And sometimes the best approach is a mixed methods design, which basically combines that hard numerical data with the human experience to give you the complete clinical picture. Now, for the exam, you absolutely have to know your jargon so you can properly evaluate research reports. Let's talk about incidence. Incidence specifically tracks only the newly occurring cases in a population over a set amount of time. So, if you want to know the number of brand new central line infections that popped up on your unit this year alone, you are looking for the incidence rate.
Contrast that with prevalence, which is more like a snapshot of all current cases on your unit at any given moment. It includes both old and new cases combined. For example, if you measure what percentage of patients in the ICU currently have a positive blood culture right at this exact second, that's prevalence. Knowing the difference between these two gives you a completely different angle on your clinical data, and it's a super high-yield concept for the test.
Okay, take a look at the evidence pyramid. It visually ranks the strength of our data. Down at the very bottom, you have expert opinion, which, hey, is great for generating hypotheses, but it's really not the strongest proof out there. As you move up the pyramid, the statistical power gets stronger and stronger. At the very top, we see systematic reviews and meta-analyses. Because they combine data from multiple studies, they have massive statistical power, which means they carry a lot more weight than a single case report when it comes time to actually influence hospital protocols and guidelines.
Sitting right below those reviews, basically near the top of the pyramid, is the Randomized Controlled Trial, or RCT. The RCT is widely considered the gold standard for individual studies. Why? Because the element of randomization significantly reduces bias when we're testing something out. For instance, if you're comparing two different skin preparation procedures for peripheral venipuncture, an RCT allows us to say with a really high level of confidence that the intervention actually caused the outcome.
But hey, even good studies can have flaws, right? When you're evaluating a research report, maybe for a unit journal club, you've got to keep an eye out for potential bias. Here are the major ones you need to spot. Selection bias means the group started off different at baseline. Performance bias means there were actual differences in the care provided. Detection bias involves inconsistencies in how the outcomes were assessed. Attrition bias happens when you lose patients to follow-up. And finally, publication bias occurs when only the positive, exciting results get published. Recognizing these specific types of biases is absolutely crucial for accurately judging study quality before you go and change your entire practice.
All right, let's transition over to Section 2, Quality Improvement in Practice.
Quality improvement is about systems improvement, not blame. I absolutely love this quote. It represents the entire core philosophy of quality improvement. Listen, when adverse events happen, and they absolutely will happen, we are looking to repair the process, not point fingers at the clinician.
We want to figure out exactly how the system broke down so we can build a much safer environment for both our patients and our teams.
To actually make this actionable at the bedside, we rely on the cyclical PDSA framework. Let's say your unit has abnormally high PICC occlusion rates. First, you plan. You look at the evidence and decide to standardize a brand new flushing protocol. Next, you do. You implement that change on a small, manageable scale. Then, you study. You measure the occlusion rates before and after the change. And finally, you act. If it worked beautifully, you adopt it hospital-wide. If it didn't, you revise it and try again. It's just a highly structured, scientific way to test solutions in the real world.
As you can see, quality improvement isn't just a one-and-done project. It's an extensive, continuous loop, and it requires serious interdisciplinary collaboration. We're talking vascular access specialists, physicians, bedside nurses, infection control, everyone working together to constantly evaluate and truly elevate patient outcomes over the long haul.
To pass your exam and honestly, just to protect your patients, you've got to be actively tracking specific clinical metrics. You simply can't improve what you don't measure. The real heavy hitters here include CLABSI rates, catheter occlusion rates, overall device dwell time, your first attempt success rate, and of course, dressing integrity. Tracking these metrics is the only way to prove whether your interventions are actually working at the bedside.
And look, when those metrics reveal that an adverse event did happen, we rely on a structured root cause analysis. We don't just throw our hands up, say mistakes happen, and move on. No, we sit down and ask 3 fundamental questions. What exactly happened? Why did it happen from a systems perspective? And most importantly, how on earth do we prevent it from ever happening again? This is exactly how we close that gap between abstract research theory and safe, everyday clinical practice.
So the final question I'm leaving you with today is this. Armed with this new knowledge of research hierarchies, study bias, and quality improvement cycles, how are you going to drive real evidence-based change the next time you walk into a patient's room? Are you going to challenge an outdated protocol? Will you advocate for a better device? The blueprint is entirely in your hands now. Thanks so much for joining me for this explainer. Keep learning, and as always, keep advocating for your patients.